introduce to you Lee Rickles. He's the Chief Information Officer at Humber Teaching NHS Foundation Trust and the Director of Interweave. And Lee is going to be chairing Future of Digital Health Records in the UK. Thank you, Lee.
So not an unusual subject for today, I would guess. Following Ming, where we've covered a number of items already of where the 10-year plan might take us and where the key components there. So really, I've got a panel of very capable and knowledgeable individuals that are going to give a bit of an overview on the of where we currently are in their areas, but also where we would see the future going, and then we'll have a bit of a conversation. So if each of them members yourself,
Hi, good morning, everybody. I'm Ayub Baya. I'm the Director of Data and Analytics at NHS England. I look after the single patient record and the federated data platform programs in NHSE. Live services like some of our normal data platforms, SaaS, etc. So it's quite a big and broad portfolio.
Yeah, looks to keep you busy. Jackie, do you want to go next?
Hi everyone, I'm the nurse and NHSGM. I've been in IA for probably about 13 years. I've organisation for lots of go lives, and now got more of
Jason.
Hi, good morning. I'm Jason Brock. I'm a GP by background. I'm also Medical Director in the Leeds office of the West Yorkshire ICB and CCIO for Interweave.
Yeah, there's no branding or as you know on your badges, yeah, there's a Interweave logo in there. I think it costs some cash or something about visibility. So what we're going to do is we're going to start with Jason, and he's just going to give a bit of a 5-10 minute play on his view, where things are going, what's good, what's bad, that type of stuff. So back to you, Jason.
Thank you, Lee. Okay, so I'm going to start off with a bit of a confession. I'm sure there's loads of us in this room that get asked to do talks like this all the time. And if you're anything like me, the first thing you'll do is go into your archive of presentations for the last 10 years, and you'll find one, change the title and the date. Bob, you're uncool, there you are. I think there's a lot of that. And over the last few years when I've been going to conferences, I have felt that there's a lot of repetitiveness about what we're hearing and the types of discussions that we're having. So we do get down to a lot of the nitty gritty sometimes around, well, fire, interoperability, all those things about how we bring about the future that we're envisaging. But what I'd like to do today is just take a step back. So I haven't brought a presentation with me at all. I'm just going to speak and share with you a few ideas that are going through my mind. So initially what I'm going to do is just tell you about my practice yesterday, because I was working as a GP yesterday, my main job, and I'm going to just tell you about some of my experiences with the IT there. I think I'd like to draw from that some of the things that we might need in the future. So we'll have a think about that as well. Following that, I'm going to move on and maybe talk about the implications of the 10-year health plan, of what we can draw from that and how things might need to change. And then we're going to finish a little bit about research, which I was asked to touch on as well. So let me take you through the first thing that I just wanted to reflect back to you from my practice yesterday. So the first thing I was doing was looking through some blood test results. Anyone that is a GP or has been in a GP practice will know that there's lots of admin, and one of the things you need to do is just go through a long list of blood test results. And it's in part of your clinical system, whichever clinical system it is, where you have that list. And the amount of information you have to go alongside that is fairly limited. It might be if someone's filled in a little bit of clinical information, you know why the blood test was done, and you can form a view about whether that's okay or not. Actually, though, sometimes that blood test might be part of a bigger investigation, and a negative blood test or a normal blood test is just as important to prompt the next action of investigation or piece of work around the clinical care of an individual. I can't see that when I'm in part of my system that is looking at blood test results. And if I'm going through 100 blood test results, I don't see necessarily all the information that's relevant, even though I'm in my single EPR. Park that. Let's go to another situation. Morning yesterday, I was working through the triage list. We use a system that sits alongside our EHR. People can ask for an appointment and put in loads of clinical information. I see what they've written, or sometimes what's been transcribed from a telephone call using transcription services, and I make a judgment, theoretically, how urgent and what the best way forward is in dealing with that individual. And actually, the system also tries to rank it as well by using a bit of what they call AI to try and work out what's urgent and what isn't. Now, if I want more information about that individual, to contextualize what that person is saying, I can click a link and go into the patient record where I've got loads of information. But when I am triaging 200 requests, have I got the time to find the right information that's going to give me the context to triage that in a safe way? Sometimes I feel not, and it's important to recognize that. And also the result of that might be that I send a patient a link and say, you know, book a face-to-face appointment in 7 days using this link. Actually, we have additional services that are around the practice, like physio or mental health services, that use the same EHR that I use, but they're in a different instance because it's a PCN service. I can't send them a link. So what I have to do is send a task to the secretaries to say, actually, or the receptionist, can you please organise an appointment for this person, get in touch with them, give them a call back and book them in with musculoskeletal service. Yeah, so that's another thing just in the system there. The third thing that I think I'd just like to bring to people's attention that I did yesterday was that I saw a person, we had a good conversation, and it was obvious that they needed to be referred to a specialist at the Acute Trust. And we're really lucky because within our system, everything's template driven within our EHR. So in order to do a referral, click a button and it populates the whole referral with the information from the consultation of that day. What do I do then? Well, I click a button to save it. I send the task to the secretary, and the secretary will, over the next couple of days, use another system that I don't use in order to process that referral. So let's just look at those 3 scenarios together and just understand what we're seeing there. Information is siloed, even within our individual systems. The information is siloed within functionalities within those individual systems. And in terms of efficiency, everything that we do is a workaround. There's lots of workarounds. So whereas I've done all the hard work of doing a referral and I click the button, everything else could be automated. But we don't do that. We're dependent on relatively inefficient services with potential for error all the way along that journey. So there is something about us having conversations typically about connecting systems together, when in point of fact, the systems themselves are a little bit fragmented. The information isn't accessible. The information doesn't support the right type of decision at the right time. So I think we just need to think about that. I'd like to move on now and think, well, actually, that's where we are now. What does the 10-year plan tell us? Well, the 10-year plan says, actually, we are going to change the business of healthcare. And the way we're going to change the business of healthcare is that we're going to be more strategic in what we buy. We're going to get all these commissioners to not buy loads of activity anymore, if you believe that. And what we're going to do is buy outcomes, which we haven't completely defined, but what it will mean is that, number one, we need more information about how care and well-being is at an individual level. But number two, actually, we're going to have to move away from this organisation and service model, start thinking about how to work in a more integrated way, take on that risk and work for a common purpose. Actually, that means that we're going to have to think about how we link not just information across providers, but actually workflow. So I think the key thing is over the last 10 years, we have spoken a lot about how do we share information and move information. For me, the next 10 years has to be about how do we bring workflow together and integrate workflow and be clear about that. And for me, that's a business change. It's not an IT thing that will follow, but it's that business change that we are going to need to concentrate on a little bit more than we have done in the past. And as part of that, what we're going to really need today is, well, actually, if this information is flowing and we're using it for better workflows, and we're bringing organisations together, we need to use more information that comes from the general well-being, general life of individuals. Because actually the biggest driver of activity in our healthcare system is how well people are in the population. So those wider things that were mentioned before around the wider determinants of health need to be part of that information, and how we affect them with the third sector, with other organisations, in neighbourhood models is going to be key to how we affect what activity and how we manage that population risk. So what we are going to need is the ability to measure what is happening across the whole system in terms of analytics for population health management type analytics, but also to create new types of research. And these new types of research have to be more focused on impact. What is it that we can do in big complex systems that are going to affect people's health and the way they choose to act and live? That is much bigger question than we've had to ask before. And trying to link that to what's happening on in terms of financial sustainability and in terms of activity at a secondary care level is something that's going to be a big challenge, which is going to push us in a different direction of research. But we can only do that if we've got the right information flowing underneath. So I suppose what I just want to finish on is say, actually, what we need to be thinking about is if we need all that type of capability going forwards, this is not necessarily just a connecting data problem. We do need to do that, and we need to create that foundation. But there's also an element of this, which is both market management and innovation. And we need to start getting a little bit clever about thinking, well, why are we doing it? Can we be really clear what it is so that we can actually start bringing that about over the next few years? I'll leave it there.
Yeah, thank you very much, Jason. If we can just give it a so thank you for that, Jason. I'll just pull Jackie's slide deck up. Do I need to share this? That one goes, Jackie. Fab. Yeah, so Jackie, you want to come here and press the buttons then? Sorry.
Tell I'm the nurse because I was asked to do a slide deck presentation. I always do what I'm told, although it's in the order, you may disagree. Anyway.
Do what's right, yeah.
The slide deck I was asked to present is the NHS single record risks proof of
Might need a technical, there's no technical people in the
Yeah.
I know that might be pushing the envelope a little bit. Yeah, okay.
So the introduction, the NHS is working towards a single digital patient record. We all know that. We've all heard that before, haven't we? And we're hearing it all over again, and that's a good thing. What's the aim? It's to unify the data across the hospital, GPs and care. We all know that again, don't we? We all want that, and actually our people believe we already do that. So our population and our citizens believe that's what we already do. What are the benefits? Faster treatment, reduced duplication and better patient outcomes. It's alarming that clinicians have to make decisions on a person in front of them with half of the information. And I think if our people knew that, they'd be really worried, but we do, and we do that every day because we never have all of the information in front of us. However, there's major risks and there must be things to be considered. And for those of us who've been around a long time, we know some of those risks, don't we? So the privacy risks, I think this is really important. So, cyber, I think, as we go into a world of, demanding that our population own their own health. We know that if they own their own health, we have better outcomes. They manage themselves better. We have a healthier population. I think it's fair to say they are nervous about sharing their data. And the more we don't invest in cyber, and we know that that's a nice to have, not a must have, the minute we put their data at risk, we lose their faith and they will opt out, and that's a place we definitely don't want to be. I think cyber is not mentioned enough in the 10-year plan, in fact, barely at all. but I did go to a national group last week with a big proposal, a big plan around cyber, and actually I had far more assurance that they are looking into it and investing in it. Although for those in providers, looking into it, investing in it is a really hard place to be, isn't it? Because if you're up against somebody who wants clinical funding for clinical stuff and you're going, please invest in cyber, in my experience, you get up to the bottom of the list. So we've got to make sure we're shouting from the rooftops about the misuse of sensitive health information. I'm a huge fan of clinicians knowing everything about the patient and the person. My clinical background is kids, neonates, big safeguarding issues. You'd be surprised the amount of my clinical social healthcare colleagues who would say to me, managing great big neonatal units with huge risk, I'm not telling you anything, actually. You don't need to know anything about that. You just need to know about the baby on the unit. Well, I do need to know if there's huge safeguarding risk, because actually I'm making clinical decisions. So actually we're a victim of our own circumstance, because clinicians do not share with each other. It's my data, not yours. I'm not going to share with you. So we have to make sure that we are sharing the sensitive data in the appropriate way with each other to make good decisions. Patient consent and transparency concerns, we've talked about that, you know, opting in, opting out, you know, making sure you're having those conversations with the people in front of you about the importance of sharing their information, and compliance with GDPR and data protection laws. If we mess around with that, we will lose our people. We don't want to do that. Cost risks to the SPR, high upfront investment in IT infrastructure. For those of us who've been around before, and it's all of that kind of stuff, we've got scars and the bruises, haven't we, you know, but actually it's the right thing to do. But there is investment needed, you know, for me, and the basic stuff I've always, for everywhere I've worked, walked in a clinician's shoes, nurses, midwives, allied health professionals, go out with them in the community, they can't connect, they're using their laptop as a clipboard, and then they're going back to their office and they're double documenting. Huge risk, huge inefficiency. So if we don't get that bit right, none of this will work. The trouble is with that conversation, none of that's sexy, is it? Because people want the shiny new bit and they want to say it's all great, and actually we've got all of this in the community and it all works. It just doesn't, and it still doesn't actually. It's still not working. So the investment in infrastructure is hugely needed. The risk of project overruns and wasted resources, it will always overrun, because you can't predict what you don't know. And actually what we know is when we have a PID, a programme of work, you know, and we live and breathe that in Health Innovation Manchester, you kind of at the beginning think we need this, but actually as the programme moves along, you need a bit more, you've got a bit of scope. So actually that will always happen, but we've got to make sure we're planning for that. And balancing the cost of frontline healthcare. And that's really difficult, isn't it? Because digital's always been seen as the nice to have, not the must have. I think with the 3 shifts in the 10-year plan, it's top of the shop now. And I'm hoping those conversations become easier in organisations. The complexity risks, so integration across multiple NHS trusts and systems. If only there was one system, if only they were interoperable, if only they spoke to each other. It's complex, it's really, really complex. And we're working at national level to make sure that we're looking at some of the solutions around getting a single patient record. The data quality for me is huge. The front end build, capturing structured data to spit it out at the back end so you can make a difference is a key thing. And actually we've never done that. I would say never ever with monolithic EPRs. We've never got to the point where we've got standardized minimum data sets running right through primary, secondary, community care that we all use, that we use the data at the back end. We all do it our own way. And actually even clinicians in the same organisation, they still don't agree standard minimum data sets. I know what you're saying, and I know NICE says that, but you know, it's optional, and actually I do mine much better. Actually, my outcomes are much better. And that's where we get into what we talked about before, predictive analytics, because actually once we can see performance and outcomes, we actually know that you're not doing that and you do have to change. For me, it's never the tech, it's the transformation, it's the hearts and minds. Training and adoption among healthcare staff, we've done that really badly, I think it's fair to say, certainly with EPRs, you know, navigate the front screen, you know, glide across there, click that, do that. You've had 6 hours training up, you go and change the way you work for the rest of your life. It just doesn't work. So we've got to be much better at how we train our end users. So we need to look at gamification training. We need to be very, very savvy with the way we train. They haven't got time to be pulled out and trained on systems. Short, snappy, bite size, with outcomes, ward to ward, feedback and reports. So I as a manager can go, actually, we're doing really well here. he's great, he's a super user, I can see all of that data, but actually his colleague isn't. They've had a go and they just can't do it. So let Lee support his colleague, or actually what do we need to do to support that person to navigate the system that they're putting their entire documentation into. Risks of delays and reduced clinical efficiency during rollout, we've all experienced that. You know, digital, I've been asked for every go live I've done. I want to see the efficiencies and I want to see the time saved. I've never managed it. I think we can do. I think Copilot for nurses will make a huge difference in terms of admin burden. But actually, when you go live, it takes them longer. Because the night before they were on paper and they knew what they were doing and they were doing it like that and they've been doing it for 20 years. But if you put a system in that they haven't been effectively trained on, and then you ask me to get the efficiencies, you're just not going to get that. And certainly not in the time scale that's expected post go live. You will get it, but you need to invest and you need to make sure that you are working with your end users to get the best benefit out of the system. So in conclusion, single patient record, I'm a huge fan of it. I think any clinician, anybody in clinical informatics can say 100% yes. Significant long-term benefits, absolutely 100%, but we've got to get it right. Privacy, cost and complexity risks must be managed and they need to be at the forefront. Success depends on strong governance, transparency and investment. And when I talk about investment, that's not putting a massive investment to front load it and then falling off dropping off the end of a cliff, because actually then we go, actually you don't need any of those staff. All go back to the job you were doing and just crack on and do. And I think I'm really pleased to hear that the conversations I'm part of at national level, we are saying that now. There's lots and lots of good conversations about how we probably haven't done it right in the last 10 years and we're acknowledging that, and that's just wonderful to hear. Careful planning is key to achieving safe, efficient and trusted use. So that's it in a nutshell.
Thank you, Jackie. Definitely some themes starting to come out for the during the presentation. So we've got Ayab coming up next. When I get to his slide deck. But let's be honest, siloed data, lots about people and culture. How do you incentivize? You know, these are current themes. Even how do we make it a long-term journey? It's a marathon, not a sprint. And even when we're sprinting, we're sort of limping a little bit. We're not the Linford Christie. We're not going to break the record. We're sort of stumbling across the finish line sometimes. So you know, a lot to pick up there. So if I hand over to you, Ayab, and you go through your bits, I think you're going to have to click on the little button there.
Thanks.
We're really high tech.
Thank you, Lee, and everybody. So, my colleagues have already said it, right? Single patient record is the right thing. It's the thing that has been trailed in the 10-year plan. The 10-year plan makes it one of the key parts, or one of the key parts of the analog to digital strategic shift that we need to achieve in the NHS. And we've spoken to the public about it. Prior to the 10-year plan being released, earlier this year, I participated in some public deliberatives. And we did a number of these deliberatives right across the country. And I took part in my home city, Leicester. And myself and Ming were both there, as was Vin, in that session as well, in that deliberative. We heard firsthand from members of the public who are just tired of repeating themselves. Right? Repeating themselves to multiple professionals. This is a simple part of patient record that I hope we'll be able to fix. The second part around, actually, as Jackie was just saying as well, Jason saying as well, the workflow element, and actually sending a task, that's all painful, really, really painful stuff. And unfortunately, right now, it's a reality for most people who work in any part of the NHS, in a hospital, or general practice, or community services. It is reality. How do we actually start to join up care? Our public already think we're doing this. The public already think something exists. And we're sitting here still talking about making it. And that tells our reality. You've heard about already from my colleagues in terms of how do you liberate the data? How do you start to share the data? How do you connect the data? But how do you give patients the control that they choose how their data is shared? And this is how we retain trust. How we make sure from a patient perspective, they drive the trust agenda and they drive how their data is used. That's something that was very clear in the deliberative, that they want to control who sees what. They don't want to be asked about sharing data from this consultant to that consultant, or this GP to that consultant, or with nothing on that. But if it's used for a secondary purpose, they want to be consulted. They want to be able to control how that data is used. That came across loud in those deliberatives. Again, you heard Lee say it, you've heard Jason say it, and you've heard Jackie say it as well. It's not about the technology, about the transformation. I spent a few months ago with John Farrington, Lee Rickles, and a number of other esteemed colleagues who have been in senior positions in NHSIT over the years. And I spent time listening to them, and spent time hearing them and what challenges they faced when they tried to do this. And there's a big lesson to learn from the past. And one of the big themes that came across to me in that session, if you hadn't done already, was actually it's all about the change. It's all about the transformation. And you made a fantastic point to me on that day to say, reduce the number of pounds spent on tech, increase the number of pounds spent on change and transformation. Right? That's a principle that I've made sure that as we're drafting the business case right now is live within that. So my aim is to say £5 to £6 in every £10 would be spent on transformation and change, and the remainder on tech. Not about the tech. The tech's the easy part. It's how do we actually drive the change and transformation? We're not just going to go about digitizing existing processes, about change and transforming existing processes to be fit for the digital age. And that's what we're trying to drive. The app becomes the front door, but the single patient record will underpin that. I think that's one of our big parts in this. And how do we get the patient to self-serve? You may have heard Secretary of State mentioned yesterday, and the whole debate about this in terms of booking a GP appointment through online services or booking an appointment through online services. He's absolutely spot on, right? If you think about it, you've been able to book a hairdresser's appointment for 10, 12 years now online. Nothing changes there. It's not revolution, but general practice, we still struggle to make the number of appointments available online. And we think it's novel and new. It's not novel and new. It's already there. And I think we've got to liberate that element to make sure that patients have that choice. Then we get to some of the more exciting parts around how do we start to personalize care through digital access. Right? The single patient record starts to enable a number of these things. So you come in, you come through the app. The app knows about you. It knows you. Amazon knows everything about you. Why can't the NHS app know about you as a patient? Right? So it starts to know you, and it starts to know, well, actually, Ayub hasn't got COPD. Ayub's saying he's got a cough. You start to connect the workflows, right? You start to say, well, actually, maybe he needs to see a doctor, but he doesn't need to see a general practice doctor. Maybe he needs to see a secondary care doctor. How can that workflow be visible straight to in general practice? But also, how can we change and digitize routes of care delivery? Right? You might not need a face-to-face consultation. You might need a test in a diagnostic center somewhere locally, in a neighborhood place. And actually, through that same process, through the new NHS Online Hospital, which has been announced today, right, there may be a digital or virtual consultation that you take part in. This is about changing and personalizing care around the person. The person is in charge of how they receive care. Now, sometimes there'll be absolutely difficult interventions that are required that you need to attend face-to-face, or you may need different types of prescription that you need to be reviewed for in a different way. But this is about personalizing the care that individuals receive. How do we make sure that there is asynchronous updates available from multiple clinicians into the single patient record? The single patient record will be a read-write system. It is not just a one-way system, right? So it will be absolutely read-write. It will drive information in. It may be a system of record for certain parts. It may not be. We haven't yet decided. I think that's really important for me to clarify that at this stage, we haven't got a solution for the single patient record. We are still in very much discovery and design phase to say, how do we get this right? Is it one big thing? Is it modular? There's lots of choices. There's lots of good work that's already happened. The shared care record is a prime example. there's learnings there. So we're not starting with base level costs at this stage, in my opinion. There are things that we can learn from and reuse or actually make that primary in the solutionizing of a single patient record. And then there is this whole category of patients, who aren't going to be on the NHS app. How do we make sure that we don't digitally exclude large sections of the population and make them feel not part of the digitizing of care? So how do we do this carefully? How do we do this equitably to ensure that whilst we can create a single patient record for the person and the staff member, we don't exclude anybody in the process? There's lots of engagement that we're doing, and I've been very clear to my teams through all the work that we've been doing is we're listening and learning. We're in this learning phase, and we are open to anybody coming to speak to us. And I'm sure Lee and my colleagues around the room who I've already spoken to previously or today will attest to that. This is a transparent and open program where we want to engage quite heavily. And it's through that engagement, I think we'll get this right. Otherwise, we will not get this right. It is not without every single one of you in this room, probably who are working in health and care roles, right? Being part of this and feeling that you're part of it, it won't be without that, it won't be a success. And then finally, my last slide is around trust and cultural transformation. Trust is foundational, and we need to make sure that through what we're driving here, we drive trust. Colleagues have already again said, in terms of privacy by design, right? So making sure that the SPR is privacy by design. We will be investing in cyber. We need to make sure and assure the general public that their data is safe. Right? How do we do that? Security by design. These are some of the principles that will ensure that we will build within the single patient record. I think through that, we'll start to create a trust-based environment that members of the public actually trust the data that lives within the single patient record and are able to engage with it. I'll be given my 10-minute flag. I'm going to stop. Thank you, and look forward to answering some questions shortly.
Very much focused around the person, the patient. We've got to remember they're absolutely key. They're why we're here. If we wasn't providing care to the patients, we probably would be doing something else instead. And it is all about people. There's no two ways about, you can have good, bad and good tech and bad tech, but if you don't have the people involved, it'll be a bit of a failure. And probably the more important one, and again, it's one that repeats, is learning from our mistakes and not repeating them. And again, that's really having that corporate knowledge, understanding that shared ownership and culture to mean that we can work effectively together in the health and care industry. Because it is the health and care industry, it's the suppliers, it's the professionals, it's the public, it's the patients, it's the professional people in this room that will make that difference. I think overall, the three presentations have been quite thought-provoking. Come from slightly different angles, and now I'm going to open it up for questions. We've got probably just a little bit less than 10 minutes. So, does anybody have a question? Yeah, do you want to go first, sir?
I'm Ross. I'm a GP partner of the Hurley Group, so fellow GP. So I very much identify with the problems you were describing about your work. But one of the things I see across all of those presentations is I always look at the marketplace, and there's a serious problem within the marketplace. So if you just take primary care EHRs, right, there's been one entrant in that marketplace in 25 years. I mean, name a digital marketplace that has a new entrant in 25 years. We have 3 suppliers now because one failed. Now, what that has created in my mind is a system whereby there's no drive to innovate, and everyone's become a jack of all trades and master of none, which is why you've got all these problems around, our pathology doesn't work quite properly, our document management doesn't work quite properly. And I just wondered what people's opinion, because there's lots of talk about transformation, and I get that and how important it is, and people, etc. and the tech's there and all the rest of it. We know the technology is there. But for me, one of the fundamental problems is the marketplace isn't right to drive those kind of initial changes required to get to the end destination. I don't know whether people have an opinion on that,
Anybody?
how it might change.
Your finger up, we'll give it to you.
Yeah, I think you're fundamentally right. I mean, there has been no market management strategy in loads of these areas. And as part of that, I think, has been this clarity about what we want this technology to actually deliver. Because everyone does things in very different ways. We don't have defined processes across our organisations, you know, in the GP practice, for instance. GPs working in next door rooms can be working in very different rooms, never mind practice down the road to that. And the same is true in a secondary care setting as well, where everyone is married to the way that they've done things for a long period of time. And so I think fundamentally we need to get better at understanding what our business processes are, care processes are, and being explicit about what we want from the market and delivering some of that.
But also the reflection on the GPIT contract. We went back before the, you know, if you went back 20 years, it was quite a vibrant market. There was a lot more vendors in there in that market. There was a lot more capabilities to bolt solutions on with some of the vendors. And we have nationally managed that market down to effectively a duopoly. So there probably is something of a reflection on, unless you want to recreate that, how do we get the benefit from the national pound, the best value for our money, based on outcomes, but not recreate another duopoly? So I think you've got a really valid point. I think that's the tension between commercially managing a contract and doing the right thing. And they don't always, unfortunately. I haven't got a brilliant answer, but there are options for, apart from, we do need to help our SMEs and our innovators get into the business, and we're really hard not to crack the NHS, because we're not the NHS, we're not national. We really aren't national, we're a load of franchises. And everybody looks to NHS England as you're the power broker when they're not in a lot of ways. It's the local trusts, and it's, I mean, practice have choice. We've only got a choice of two, so at least it's better than a Model T Ford, to be fair. But yeah, so again, it's a really valid point, and it's definitely one we need to pick up. Do you want to comment on that, Aaron?
Just really quickly, I think the centre has a role around market making. Right? So I think in the new centre, whatever the new centre is in due course, I think one of those responsibilities will be around market shaping, market making. And how do we encourage more organisation, more SME, niche companies in software terms to come to the market, to bring their solutions, we encourage and we create that environment. I think that we've definitely got to do more of, and in general practice world, it's not good enough.
Which is why I think your idea of the modular thing is important, because if you make it modular, you've got an opportunity
Yeah.
to then
The agnostic.
SMEs create very niche areas to drive business innovation.
There has been some, not in GP, I'm afraid, that, you know, you damned on the GP contract there. But there have been some quite interesting market entrants in different areas of the system. But yeah, unfortunately, just not.
I think that was the thing that interested me getting involved in Interweaves.
Yes,
The
well, we're
potential.
quite unique in that. Yeah.
No advertising, but what intrigued me was that within all the systems, being able to free up the data in some way from the silos that they sit in, creates the platform where innovators can say, actually, what are we going to do with this? What new things can we create that fit together as modules that allow us to do things more effectively?
We'll stop the selling, and we'll go to the next question.
Question regarding the single patient record. I know it's part of the 10 years plan, but have you projected like when the first phase of it will roll out, or the processing on that? And my just at the back of that is, you mentioned about getting opinions. People are welcome to give opinion, but have you actually thought about having targeted audience, on maybe a structured way of having targeted audience, and who would those audience be, and how are you also looking into capturing those audience?
Yes, I'll answer your second question first. So we have already got patient groups that we're working with and talking to. We've got workforce representatives that we're also speaking with. Sure that we're starting to have those conversations sooner rather than later. Technically, this program shouldn't start, 'cause it's not a funded program until next financial year. But the way the NHS works, you've got to start it sooner because you'll never get to that point, otherwise you've lost another year. So we have got the policy groups that we are engaging with. We're trying to create some more general panels as well for engagement with public sessions, with the works as a whole. And then finally, your first question, when will it be ready? And there's a lot of work to do before we can get there and say, when will it be ready? And I know the 10-year plan gives some commitments and timelines. That's absolutely what we're working towards. That's my political answer, if you like. But at the same time, I think there'll be some delivery that gets staggered over that period. So it won't be a big bang. Big bangs don't work. We know that, we've tried that. It doesn't always work. So I think there's a measured deployment plan here.
The shareholders love big banks though, because they get shed loads of money. Go on, Anna. Sorry, I know you got your hand up, Ian, but you'll have to go at lunch or something. Anna, do you want to go? And that'll be the last question, I'm afraid, because I'm getting told we're running out of time.
Okay, sorry, I just want to ask, we've been talking a lot about the benefits of single patient records, shared records. I just want to know, among the nations, England, Wales, Scotland, how much of that conversation is being held around accessing records across different NHS? Because I said, for example, I recently had an experience where we moved from Wales to England, and my son, we tried to get him vaccinated, and we had to wait for a while because they weren't able to access his records from NHS Wales. So I'm just wondering how much of that conversation is being held around accessing records across the different countries in the UK.
It's a really good question. It just needs it's a conversation that's happening, but nothing's really progressing at any rate pace at the moment. But it's a massive issue, that boundary issue between Wales and Scotland and Northern Ireland. It's one that the defence organisations need to crack. Defence doesn't care about England, Scotland, Wales, and Northern Ireland. But they've got a different challenge there. It's one that we've got to grow up to and start looking at a UK approach of how we do things. So things like the international patient. Tell me what it is.
International patient summary.
International patient summary. Would it be a massive move forward to at least sharing a level of information, at least between the home nations? It just doesn't happen. Then the conversations happen, but it's an opportunity.
Yeah, it's an opportunity. We made it happen during COVID. I was involved in that personally, so I know that we made it happen during COVID for sharing data for vaccines between England and Wales at least. Scotland was harder. We got there. Yeah, Wales was something that we made happen. We made it happen both, but we know that it's possible. Yeah. Figure out how to make sure that it's universal across England, Wales, and Scotland.
It's a brilliant question. I think that wraps this session up. So if we could just our appreciation for the speakers again.